right. Hello, everybody. This is Jay Spielvogel. I am Vice President of Business Development and Program Management here at Technology Access Partners. And we want to welcome you all and thank you for joining us today. Again, we'll be talking about developing economic sales models for medical device and how to integrate that into your sales process. And I'm going to introduce Martin Gold. He's my partner, and he will be taking us all through this presentation. As we go through it, we will save time in the end of the presentation for questions and answers. So please feel free to either direct any questions either to myself or Martin as we go through it. And again, we welcome you all here. So Martin.
Thank you, Jay. So my name is Martin Gold. I'm principal and co-founder of Technology Access Partners. And today we're going to be discussing developing economic sales models for medical devices. Before we jump in, I just want to kind of mention a couple of housekeeping issues. As Jay mentioned, you can actually ask questions. Feel free to ask throughout the program as kind of things pop into your mind. There's a question box, and you can actually type it in, and we will basically reserve a few minutes at the end to go through them. The other housekeeping issue, when you log off from the webinar, is going to be a one-question survey, and I'd appreciate if you could take a moment and just complete the survey. It's basically asking if you have any interest in some of the classes that we're going to be running via webinar around more in-depth economic model development. So if any of those topics are of interest, please just click which ones are and submit them. So as we get into this, what I'm going to do is go through the agenda and look at the different components of developing economic sales models. So first we're going to talk about the different kinds of models, economic sales models or economic models in general. We're going to look at cost benefit, cost effectiveness, cost comparison or cost avoidance, one and the same, and then financial performance. After that, we're going to take a look at the economic sales model development process. So a process, and we have 6 steps for developing and implementing models. So we're going to go through the 6 steps of establishing clinical domains, evaluating the clinical literature to support the modeling process, then translating those clinical domains or clinical data into economic data. And we're going to talk about sources of data to build the model, and there are many, many sources. So we're going to focus on a few newer ones, and then some you might be familiar with, which are really great sources of free data. And then we'll talk about the difference between economic, clinical, Medicare versus commercial data, and then some public versus fee-based or free versus fee-based data sources. And then we're going to follow up with the sales process and implementation. In other words, evaluating the sales process for your products within your company, excuse me, incorporating the sales process into the model because that is necessary. And then finally, how you successfully implement that model within the sales force, because that's always the goal, obviously. Is you put in all the time and effort in your company to develop an economic sales model, you want it to be actually utilized by your sales force. So to begin, let's talk about the types of models, the more common models that you see out there, and we'll call them by analyses type. So oftentimes you'll see cost-benefit analysis. That's not a new model. That's not a new analysis. It's been around many, many years and has been a core for health policy people for decades. And the concept of cost-benefit analysis, just so we understand the kinds of models we're talking about, it's a model that compares the cost, the financial cost, with the benefits of 2 or more healthcare treatments or programs. So looking at healthcare interventions that have the same or better benefit at a lower cost. Ultimately, it's looking at, let's say, and this is very common, you'll see a cost-benefit analysis oftentimes in a health policy framework where a government or could it be Medicare or Medicaid, Child Health Plus, they're trying to determine 2 different courses of treatment and the cost associated with those 2 courses of treatment, and then how that impacts the benefit side. What benefit are they getting for that cost? So which of the 2 different opportunities or pathways for treatment provide the most benefit? Again, very, very common in a health policy environment. The next piece you see is a cost-effectiveness analysis. So cost-benefit analysis you'll often see as CDA, cost-effectiveness you'll often see as CEA, and the resulting models are obviously cost-benefit and cost-effectiveness models. Now, cost effectiveness analysis or the resulting model, it's similar to cost benefit, but it's used when the benefits cannot be measured in financial terms of dollars. So very similar to a CBA, cost benefit analysis, but ultimately it's usually measured in a very different way. And you might be familiar with something called QALYs, quality adjusted life years, or daily disability adjusted life years. So the concept is a CEA, cost effectiveness analysis, is very close to CBA, but what you're measuring, the benefit that's being measured, is typically how long you're extending a person's life, a patient's life. This is very common when looking at pharmaceuticals. It could often be used by healthcare payers, so insurance companies, to determine what kind of results are they getting from implementing a particular treatment or therapy as one of their benefits. So CEA and CBA are most often used in health policy, pharmaceutical research. When looking at it from a payer's perspective, they'll do some of these. So what are the two that are more common when we talk about medical devices? We call it a cost comparison analysis and financial pro forma. So cost comparison, I also call it cost avoidance. It has a lot of different meanings, but ultimately, if you think about it, a cost comparison is a model that compares the financial cost of two or more healthcare treatments or programs, and the model determines the difference in treatment costs and complications. So we're not necessarily doing an analysis like we would with a cost-benefit analysis, where we're looking at the cost of two different treatments and then determining what is the financial benefit that's being gained from it. Here what we're doing is we're looking at two different courses of treatment, and oftentimes, we'll look at a sample of this, it's a model where on the left side you have what I'll call the gold standard of care, the way treatment is currently being done. The right side, you'll have your intervention or your product, your technology, your procedure, and the cost associated with that. And then we start to tally up the differences in mortality, the differences in length of stay, the differences in intraoperative complications, and it's all based on cost. We're tying it back to a direct dollar amount. And then we come up with the delta, or the difference between the two. And the intent of a cost comparison analysis is to say, if we do a cost comparison, we can go back to a hospital, for example, and say, if you use our technology for this procedure, you'll end up saving yourself X number of dollars by avoiding certain costs. So hence the cost avoidance model. The other very common approach to modeling for medical devices is a financial pro forma, which a lot of us are very familiar with. And that concept is basically looking at the direct reimbursement of a procedure or program, comparing that to the direct expense, and then looking at the expected net reimbursement. And again, there's a whole lot of compliance that needs to go into a financial pro forma. Over the last decade or so, there have been a lot of issues with companies, medical device companies, presenting a pro forma that talks about expenses, that talks about revenue generation. Medicare and the Office of the Inspector General, so OIG in particular, has certain red flags in terms of the way you develop these kinds of pro formas. So again, this kind of a model of pro forma is only typically relevant when you're talking about a separately reimbursable type of product or procedure. So if you're not separately, or if you're not deriving additional or separate reimbursement, it's difficult to really do a true pro forma that makes sense. So oftentimes we'll opt for the cost comparison analysis. So now let's take a look at a couple of different examples. And again, if you have any questions, please feel free to type them in the chat box, in the questions box, and we'll address them as we go along, and we'll save a couple of minutes at the end. So this is an example of a cost comparison analysis. And as I mentioned, you have a procedure that's primarily being performed open, and we call it open colectomy, versus taking a minimally invasive approach, an MIS approach to colectomy. So this is a very common approach to modeling the cost comparison or cost avoidance when you're looking at a procedure or technology that facilitates the movement of a gold standard approach, an open procedure, to a minimally invasive approach. And the challenge with this kind of an approach, obviously, with this kind of modeling, is that we all know when you work with MIS, minimally invasive, you typically drive up the hospital's direct costs and supplies for the procedure. So supplies, disposables, there might be a significant capital investment to get the equipment in place. So the idea is showing a hospital as part of your sales process that there are cost savings associated with a minimally invasive procedure by reducing length of stay, reducing OR time. Potentially OR time goes up initially at a hospital with a surgeon, but over time comes down. Reducing complication rates is almost always the case going from open to minimally invasive. We're going to talk about a lot of other what I'll call value propositions where cost savings occur, in terms of hospital-acquired conditions. So surgical site infections, obviously, going from an open to minimally invasive reduces SSIs, just overall infection rates, deep tissue infection, and things like that. So that's the concept of, and we even look at, for instance, blood transfusion rate percentages and costs of blood transfusions. So we look at the difference between the two, left side, right side. Right side would be the intervention that we're actually putting in place. Again, our product, our technology. That's the right side of the equation. If we take a look at the results or the output of this kind of a model, it would look something like this. And again, we have the opportunity to say to a hospital, well, how many procedures are you going to be performing open versus MIS? Because again, a lot of that is driven by the surgeon's preference. So even if we step into a hospital with this kind of a fantastic model, the idea of trying to drive 100% compliance of moving 100% of the surgeons and 100% of the procedures from open to MIS is not possible. So we have to be able to model to a hospital a reasonable approach to it, and that's part of the sales process, which we'll talk about in a little while. But if you look at what the output typically looks like, we're trying to take an economic approach for discussing per diem costs, readmission costs, cost of complications, the blood transfusions, as I talked about, and then coming up with a comparison. So talking about, on the left side, comparative procedure costs. Here's what, on a per procedure basis, you're paying, or the hospital could expect to incur, let's say, with complication rates and everything else, when doing an open procedure versus doing MIS. And then, again, annualizing it on the right side, keeping in mind, when you develop these kinds of models, we use baselines in terms of plug numbers or baseline numbers, because until you're involved in a sales process, and again, I'll talk about that in a little bit, you're not going to have exact data for that hospital. So you're coming in with what I call credible baseline data, and the idea is through the sales process, sales pipeline, to start to have conversations that help you collect and then replace the baseline numbers with the hospital's own experiences. And that's, again, the way we integrate the models into the sales process. Let's look at an example of a typical pro forma. And again, concept, if you look at the left side, projected reimbursement, and then projected cost per month. And then on the right side, we're taking a look at, in this case, it's a payer mix adjustment. How much Medicare versus commercial are we going to be seeing? And then beyond that, we also take a look at the output. What are we looking at? Projected waived reimbursement, projected acquisition costs. So again, this is strictly a revenue minus expenses, come up with net reimbursement type approach. So again, as I mentioned, it's really only going to be relevant when you have a product or a procedure that is a brand new procedure that drives direct reimbursement. In other words, if it's an add-on to an existing procedure that the hospital's already getting paid for under a DRG by Medicare or anybody else, a per diem, whatever it is, case rate, it's very difficult to do this because typically, unless you have a very, very low expense, you're going to obviously reduce their net reimbursement significantly, the direct net reimbursement, and that's always going to be a problem when you present this from a sales perspective. So let's look at the model development process. And again, if there are any questions, just please kind of type them in, pop them right out there. The development process. Again, 6 steps. We put it together in a 6-step process. And this is ultimately my process, the way we do it here, the way I typically have done it, and I've kind of fine-tuned this approach over the years. People might do it differently, but I've always found that this is the quickest, most straightforward approach to actually developing economic sales models. So if we talk about, and in this case, we're generally focusing on the cost avoidance or cost comparison type models. Again, the pro formas are a little bit more straightforward because pro formas typically it's direct expense minus direct reimbursement, or direct reimbursement minus direct expense gives you your net. Here we're talking about how do we develop a sales model where we show the economic and clinical benefits of what we bring to the table when we're not directly reimbursable. So step one, I call it establishing the clinical domains. And the clinical domains are basically the clinical data points that associate your value proposition with your product. So for instance, we identify the clinical value propositions for the procedure, for the product, again, determining whether it's the left side of the equation for the gold standard, the right side for ours. What are the pressure points, value proposition, clinical points where we can impact, that can be impacted by what we do? Here's an example of again, some very typical ones, mortality. And we'll talk about mortality data in general. It's really kind of 30-day mortality and 30-day readmission is really becoming a significant issue right now because of the way Medicare is collecting the data. So, if you're in cardiovascular, ultimately, or cardiovascular or orthopedics, this has become a major issue. So mortality, readmission, obviously. Right now, readmission, not only is it being tracked and published, hospitals are actually being dinged, as we know, from the Accountable Care, Affordable Care Act. So they have a withheld that Medicare places on top of each DRG that they have to basically earn back based on reducing readmission in several different areas. Intraoperative complications is another clinical domain. And again, what we're focused on are the kinds of clinical domains that are truly meaningful to a hospital right now. So what I do is I weight the value proposition, the clinical value propositions that a technology can provide with what's really going to resonate with the bottom line of a hospital. There are certain things that just aren't going to resonate as much as others. So we talk about intraoperative complications. Intraoperative complications, we know, drive up total cost, total length of stay, can be incredibly expensive. Often a longer ICU stay or an ICU stay in general that wasn't necessary prior to the intraoperative complication. Another issue, hospital-acquired conditions. Right now we know that if hospital-acquired infections is a problem, as it is for probably about 25% of hospitals, there's an automatic 1% withhold by Medicare off the DRG payment right off the top. They're getting dinged. So hospital-acquired conditions is a major issue for them, as well as the fact that they're not going to get paid more for hospital-acquired conditions. So if a patient has a surgical site infection or some kind of hospital-acquired infection and they become a more acute patient staying longer, hospital doesn't get paid for that. So that's a huge issue. Then we talk about blood and other supply use, which I think is a lesser of an economic value right now that resonates. Supply use definitely resonates if you can help them avoid some really significant costly implantable item or something else. The other issue, length of stay. Length of stay has, actually I produced a little bit of a video on that on our YouTube channel talking about what is the value of the value proposition of reducing length of stays. It really is significant as we think it is. And unfortunately, based on my experience managing hospitals, being in hospital finance, as well as working with a lot of hospitals and medical devices and research we've done, it's not as impactful as you think it is, unfortunately, because of the way the expenses get tiered. Each day in the hospital, the patient's expense goes down further and further, so it's not a straight line division across all the days. Ultimately, if we can focus in by bed type, in other words, if our value proposition says, hey, we can reduce the length of stay in the ICU by, let's say, 3 days, that's pretty significant because the ICU is the most expensive place to be for a patient. So ultimately, it's talking about what's going to truly resonate, what really impacts the hospital's bottom line from a clinical perspective right now. Then we go to step 2. Once we establish the clinical domains where we can truly make an impact, then we take a look at, okay, let's look at evaluating the clinical literature. Can we develop enough clinical literature or enough baseline data from the clinical literature to support our analysis? So what I typically would do is I would evaluate the clinical literature and look at the strength of the evidence. So I wouldn't take every single study and say, okay, we've got numbers here, because it's about creating a credible baseline that ultimately we would hope are replaced by the hospital's own experiential data, but we got to start somewhere. So some of the things that I take a look at, I look at the study location. Was it a U.S.-based study or was it a study that was done outside the U.S.? Because ultimately, if we start with baseline data in our model, hospital CFOs, medical directors, even some of the department service line administrators, especially if you're working with a center of excellence service line, they're going to question the data, the baseline data that you're using, and the salesperson is going to have to be able to explain the source of the data. I look at the study design. Are we talking about a randomized controlled trial? Are we talking about just a case series? Are we talking about a prospective versus a retrospective analysis, a meta-analysis? So I look at the study design, and obviously a randomized controlled trial is at the gold standard. That's the top, the very top. But again, I've used even a case study. I've used single center case series. It depends the story that we want to be telling. And as long as the models are upfront and clear and the salesperson can explain the source of the data, then it's credible data. We look at study size, obviously. We look at the relevance to the clinical domains that we're studying. You know, does the data support in a relevant way the primary clinical data points we're trying to build? I'll look at the dates of the studies, obviously, because some of the things, I mean, if we look at surgical infections, surgical site infections, or deep tissue infections, things like that, a lot of progress has been made, especially in the last few years in hospitals, with a lot of the quality programs, the sepsis programs, a lot of the HAI programs. So there's often an HAC team. A lot of those programs have reduced the incidence of certain kinds of conditions and infections. So we have to be cognizant of, are we taking data that's truly relevant for a hospital's business model right now? And again, it's understanding what is the initiative going on with your hospital customers, what are their current business initiatives, and then how do we compare to that? How do we align with that? And then finally, I use a tool called Legend, L-E-G-E-N-D, to grade the strength of the evidence. So when you have all this clinical data, all this study data, how do we put it into some meaningful format to let us say, this is good, this isn't as good, I want to use this data point but not that data point. So Legend, and again, it's not my development, but Legend was developed by Cincinnati Children's Hospital, and I like it because Legend stands for Let Evidence Guide Every New Decision. So if I'm trying to make sense of all of the clinical literature that I'm digging through, and you all know how quickly the studies mount up, and so you're looking at thousands of papers and studies in some areas, certainly in orthopedics and cardiovascular, it just goes on and on. So this idea that they put together was really a process, and there's a lot more to this, and if you have time, definitely go on Cincinnati Children's website and take a look at their Legend process. It was really meant to be the underpinnings of evidence-based treatment protocols within their institution. So they developed this basically to be able to support their treatment protocols and establish treatment protocols within their institution. Part of what this particular table is actually their table of evidence levels that they use to grade different studies. And if you look down the left side, the domain of clinical question is ultimately they're asking what is the basic clinical question being addressed within a particular study. For example, is it an intervention, a treatment, a therapy, quality improvement? Is the intention of the study to assist in the diagnosis or assessment of a patient population or prognosis or etiology risk factors? In other words, studies that say patients that have comorbid conditions are more likely to have infections. So they start with looking at the domain of the clinical question being addressed in any particular study. Beyond that, then they start to move all the way out to the right across the top. Is it a systematic review, meta-analysis? Is it an RCT, a randomized controlled a trial, or a CCT, which is just a basic controlled clinical trial without randomization? And it keeps going. So cohort perspective, cohort retrospective, case-controlled studies, longitudinal, on and on. So ultimately what they do is they're able to take all the study data that they have and begin to lay it out and determine, based on what they're trying to accomplish, what is the value of the data that they're now analyzing. So it's important to just use some kind of framework. And again, this is often falling under the header of evidence-based medicine, EBM, using evidence, clinical data, weighting the clinical data, evaluating it to determine what is the value of the data you're looking at. And again, you don't have to use Legend. I just happen to like this because it kind of is a very actionable approach. And to me, it makes sense because it helps me sort through and lay out all the data points. Let's take a look at step 3. So step 3, if once we have all of this done and we've analyzed all the data that we're going to be analyzing and all the studies, and we've kind of graded everything and we know where we want to be with which clinical domains, we then have to translate our clinical domains into economic domains. And I get this all the time. People ask, how do I know, if I want to create a cost comparison or cost avoidance model, we know we can impact length of stay or we can impact SSIs, but there's no data to say, what does that mean economically for a product or a procedure? So the idea is we tie it back by looking at this general cost of SSI, and if you can get as specific as possible in the indication. So oftentimes, for example, cost of SSI or HAI, if I'm working on a cardiovascular procedure, for example, I was working on replacement of ICDs, implantable cardioverter defibrillators. So looking at the incidence of deep tissue infection and SSI, surgical site infections. So if I look at papers that look at the cost associated with deep tissue, we get a sense, and again, focusing on chest, focusing on replacement, cutting a pocket, replacing the device, then I try and tie it back to what is the incidence. So find out those clinical domains that give me the incidence, that give me the percentages, and we tie the two together. So if we have a 2% SSI rate for replacement devices, if I have another economic study, there aren't as many of those, unfortunately, for a lot of different indications, I try to tie the two back together to say, okay, now we know when we do have a deep tissue or an SSI for that kind of procedure, here's what it's generally going to cost. We look at cost of intraoperative complications, and again, as close as you can get. For example, I wouldn't take that former example I just used where we're looking at replacement of an ICD and relate those costs back to, let's say, deep tissue or an SSI for hip replacement, total hip arthroplasty or total knee arthroplasty, TKA or THA, because it's not the same procedure. It's the same with intraoperative complications. You're going to have a different cost associated with different kinds of procedures. You can get ballpark if you can get within the same body system, orthopedic, cardiovascular, neurological, things like that. I'll look at costs of related readmissions. Obviously, that's huge, especially not only is there increased costs right now, and hospitals don't get paid for the admission, but oftentimes they're getting dinged for it as well if they're one of the hospitals that has a poor readmission rate. They're not hitting the national benchmarks. Another piece, costs or charges per patient discharge. We want to look at what are the total costs of a particular patient discharge, especially if there are complications, and is there a way to impact that? And right now, a lot of what we unfortunately have to look at is chart-based data, and we'll look at a couple of examples of where this data resides and how we get a hold of it. But anybody that's worked with mid-par data basically knows, oftentimes it's going to be based on charge-related data. Most of Medicare's data is charged, and then they kind of adjust it back down by using a cost-to-charge ratio adjustment. There's even a lot of discussion right now in the industry, in hospitals and healthcare, to try to minimize these huge swings and how to deal with some of that. So finally, we do look, as I said, length of stay by bed type. So what we're trying to do is look at ICU versus med-surg. So if we're dealing with pediatrics, it's the PICU, it could be the NICU, it could be the cardiac care unit, the CCU, the ICU, the MICU, the medical ICU unit. And those are the most costly places to be versus if somebody's in just a typical med-surg bed, or again, if it's pediatrics, if they're just in the bassinet, so they're in pediatrics, So ultimately, it's not just what is the total length of stay, but what is the patient experience clinically over the course of that stay, which is why it's so important to start with the clinical domains first and then evolve into the economic domains. So let's talk about some sources of data. And again, if anybody has any questions, feel free to kind of type them in that question box so that we can discuss it. If we talk about sources of data to build models, and again, we're going to be giving an entire class on this because it's such a huge area. It would take, it takes several hours just to discuss sources of data, validity of data, how do you utilize the data. Some basic sources of data right now, and you'll see it out there. I've begun to really dig into the data.medicare.gov site and their data. You're able to download all of the data in CSV files. So they now, the three I focus on right now, 30-day mortality, and readmission rates, surgical complications, and then HAIs, healthcare-associated infections. So this is the data right now that is being collected to support the hospital compare website. And again, as I said, you can download those entire data sets. What I've been looking at is taking those data files and then linking them crosswise to things like the SSI financial impact data for hospitals, the ones that are being dinged, coming up with, excuse me, with the total financial penalties that every single hospital is now incurring, so that when I'm building models, I can say, walking in with a particular product, we can target a hospital and say, oh, we know right now you're losing 2.5% right off the top of your Medicare revenue because of all the issues that you're having. So there's a way to link a lot of these data sets together. So I would definitely recommend that you talk about or look at some of the data on the Medicare data.medicare.gov. It's not the Medicare.gov site. If you go to the hospital compare website, it will link you back to the data.medicare.gov site. There's a lot of other data that you can kind of dig through there. Also, Medicare provider utilization and payment data is a new data set that's actually, well, newer data set that's actually being released by CMS right now. Looks at, I think, the top 100 procedures or DRGs right now in a hospital. So it's not totally comprehensive, but it's charge data by hospital, charge and reimbursement data by hospital for those procedures, and they have the same for physicians. There's going to be a lot more Medicare data being made available shortly. With the new transparency initiative going on, there was a whole lot of data that CMS wanted to release that unfortunately they weren't right now to release. There were some restrictions. So you're going to see a lot more data being available directly through Medicare. And again, there's always the standard MedPart data. So it's the Medicare provider charge data and utilization data that's always been available. That's a little bit more difficult to work with as an individual. In other words, you can't just take it, load it on your computer, and pull it up in Excel or Access. It's got to be done with a much more robust statistical package or data package. So again, dig around the data.medicare.gov site. You're going to find a lot of useful data there. Other data that I often go back to again and again, HICCUP data, healthcare cost and utilization project data. So you see the website there, hcup-us.ahrq.gov. This is data that's been collected for many years by AHRQ, and it's focused on the data collected through the National Inpatient Sample, the NIS. The other database I tend to use frequently is the State Ambulatory Surgery and Services Database. Again, it's free. HICCUP has its own built-in web-based tool to analyze data. It'll give you a lot of great information on ICD-9 procedure codes, diagnosis codes. You can cross-map and analyze data. The only thing, and it also, by the way, it's both Medicare, Medicaid, and commercial, as well as self-pay. So it cuts across all payers. The only thing to keep in mind is that right now it is based on the nationwide national inpatient sample. So there's a sampling. It is not every single claim that's generated. It's not claims-based. It's a subset, and then HICCUP uses a calculation that actually has been pretty reliable. You'll find HICCUP data being the basis for quite a few economic studies for many years. So it is considered a reliable source. It's free, and again, definitely you should take a look at that if you're looking for utilization data. So again, I could go on, but we don't have time, and ultimately, as I said, we will be offering some courses, online courses, webinar-based courses like this one, where you can learn more about how to utilize data more effectively, combining databases and things like that, a more advanced data course. So if we look at step four, evaluating the sales process. So we're getting to the point where we now have our data, we have our domains, our clinical, our economic, and we have to think about now, it's all lined up, we've evaluated the literature, we have to figure out what kind of model are we building, number one, what is this model going to look like, and how do we make it usable? So the first step in physically building the model, and I call it building the interface, what the user will be seeing and working with, not the data sets behind it, but what is the user looking at, as well as what is the output. So what gets left behind. So when you evaluate your sales process, you have to, and again, step 4, you have to look at a couple of things. Number 1, critical, the skill level of the end user. And by that I mean who's working with the model in your company, in your team. Is it a salesperson? Is it a clinical person? Is it going to be a regional manager? Is it going to be a national accounts person? Is it going to be a delegated reimbursement person? So ultimately you have to think about what is the skill level of the individual that is going to be working with that model. Because if we're trying, and again, I've built models for every level of skill that I just mentioned, from salesperson all the way up to a dedicated reimbursement team or health economics team. So you have to think about, is this a model that you build before you even build it? Is it a model that I want the salesperson to be presenting in the sales cycle, that they will be in front of the customer, whoever we decide that stakeholder customer is at the hospital? What's the skill level of the person I'm working with? The next key question that you have to address is the stage within the sales pipeline during which the model will be used. And in other words, once we determine who's using the model, we have to decide where in the sales process are they using that model. In other words, are they using it by stepping in and working with the nurses around the OR? Are we expecting them to kind of work up by the time they've gotten the clinicians on board, the nurses on board? Are they then going to be presenting a model? Is it something that is strictly for presentation to the value analysis committee, to the VAC? So again, it's where within the sales pipeline that model will be used. And oftentimes the challenge is the salespeople might not be tracking a very strict sales process. So oftentimes the question of where do I use that model, where do I get the best results, the best leverage in the sales process, they're not sure. You know, when it's a reimbursement team or a national accounts team, oftentimes they're called in. They can evaluate, is this the right time to be speaking to certain people and presenting? Should we wait? Do we need other stakeholders involved? Ultimately, it's about determining where that model is going to be leveraged. Next piece, critical, very critical. Who's the audience or the hospital stakeholders that we'll be presenting this model to? As I mentioned, is it going to be nursing? And if it's nursing, do they have the capability to really understand and evaluate a high-level cost avoidance model? Does it make sense financially for them? Do they have the skill or interest to do that? If it's a value analysis team, you know, how do I get in front of that financial person to really explain the model? Because you can't just send off the results and hope that somebody understands it. You can't do that. You can't actually interface with the financial people on the VAC committee, typically not during the committee meetings, but prior to that. We do that all the time when we work with salespeople in the field. The next key piece is, do we build the model as an interactive tool versus collecting data and sharing the results? And what I mean by that is, if we build a model that is interactive, then what we're saying is we're sitting down with all of the key stakeholders, and there are going to be a select number in any sales process, depending upon what you're selling, and say to them, do you have a good understanding of what your infection rate is in cardiovascular, in the, I don't know, in orthopedics, total knee replacement? Do you have an understanding of what your infection rate is, what your re-op rates are, readmission rates? You know, you have to make sure you're talking to the right stakeholders to build that model interactively as we're having the sales conversations, versus collecting the data and sharing the results. Meaning, as a salesperson, I have my model that you've developed, and I know I have to meet with certain stakeholders and speak with those stakeholders and get the information from them. So I have kind of a data collection form. And then I take that back and I start to plug the numbers in, and I come back with the results. So again, the two options are, do we build it interactively while actually having the sales call with the stakeholders, which means I have to be very precise about that number C, or that item C, the audience and the stakeholders with who I'm selling to and using the model with? Or do I bring data collection forms and then kind of navigate my way to the right people where they can share the forms with each other and with the right teams, and then ultimately I get that form back and I build it myself. And then finally, in step 4, evaluating the sales process, I have to figure out, what's my leave behind? In other words, what's the piece of collateral being generated by this particular tool, this model? Is it the model itself? Do I complete the model and give it to the hospital stakeholders, assuming that I'm giving it to the right people, that they know what it is and how to use it? And that's assuming we've already completed it and the data is valid. Sometimes you see very often salespeople will take the model and just not do anything with it, leave it with baseline data, and give it to the hospital, give it to someone who connects back to the value analysis committee. I'd say 99 out of 100 times, my experience is the hospital people that end up with that model in their hands don't know what to do with it, never use it, or use it incorrectly, which is even worse. They come up with numbers that are actually detrimental to you because they've misused the tool. Versus, as we said before, collecting the data and then sharing the results, and the results can be printed results. Some of the examples I showed you earlier where we get these pretty graphs and nice numbers and it's clear. So it's the concept of what do you want to leave behind. And there are a couple of different dangers in leaving the model itself behind. And by dangers, I'm saying, kind of red flags. Again, if you leave a model behind, the person or people you leave it with, the stakeholders, might not know what to do with it and might come up with negative results simply from lack of understanding of the model. Or perhaps it could be misused in a way that creates some kind of compliance issue. So a lot of the companies I work with, I recommend not to typically leave a model behind, but have them print out very clear, very precise results. And then number 5, in sales process and implementation, incorporating the sales process into the model itself. And again, we kind of talked about that. At what stage of the sales pipeline will the model be utilized? So I kind of brought that up. Again, we have to understand where the model is being used with which stakeholders, because we have to make sure that we're actually in front of people that understand the economics around what you're trying to sell, or you're given the opportunity to explain it to them. I always like to say, follow the money. That's what I tell the salespeople when I'm working with them. And by that I mean, if I have to understand who's signing the purchase order, whose budget is it coming out of, who's going to be financially responsible for it, that's how I follow the money. Those are the people that typically need to see the model and understand the economics. So if I'm going in with a product that is being utilized in the OR, but it is a neurosurgical product, then I need to make sure not only am I in front of an OR manager, not only am I in front of the neurosurgeon, but I'm also in front of the administrator of neurosurgery, as well as probably the chief, so the MD, head of the department, so both the administrative head and the MD, so the service line administrator and the doctor as well. And then ultimately, I probably will have to get in front of the value analysis committee, either directly or indirectly through someone else. So there are a lot of different people when we take a look at the concept of following the money. Whose budget is this impacting directly? Who's going to be signing the purchase order for me? Whose allocation, if it's capital, whose allocation expense or capital is it going to be? Who's involved in making that decision? And then those are the people typically I'd want to produce a model for and present to. So again, the concept of which stakeholders will the model be utilized with, data collection versus presentation of results, that's how we're incorporating into the model. All of this needs to be thought through clearly. And then even the concept of pro forma versus cost avoidance model, which we talked about earlier, and really it comes down to, are you generating separate reimbursement, a brand new DRG for them, or are you possibly increasing the acuity level of the DRG? If not, if you're what we call in hospital finance an add-on expense. In other words, clinically you might do a phenomenal job at reducing complication, readmission, and everything else, but unfortunately you're increasing the direct expense in that procedure without generating any new reimbursement. So you're just an add-on expense to the procedure. And you have to be very cognizant of that, because unfortunately right now a lot of the financial people, while they are focused on value propositions of all the other things we talked about, they're still very sensitive to what is your direct expense and your add-on expense to a procedure. So that's changing a lot, and I think there's a lot of value because, again, all the tiebacks we just discussed to readmission reduction, value-based purchasing, all the losses hospitals are incurring. If you can show how you can contribute to helping them recoup that, that is a financial incentive to them, not just a clinical incentive. And then finally, most importantly, will the product be referred for value analysis to VAC? Because if yes, then the model should be completed earlier in the sales process so that ultimately we can sit down with a financial person who's responsible for doing the financial analysis for the VAC and have a discussion with them prior to the meeting. Once they go into the meeting, nobody's going to look at the model, nobody's going to look at the results. Somebody has already made a decision. Unfortunately, that happens a lot. So ultimately, we really need to make sure we connect with whoever's doing the financial analysis for the VAC and then have that discussion with them. And ultimately, we talk about stakeholder concerns vary. And this is very much the case. If you look at just a couple of key stakeholders that we might interface with, and you may or may not interface with these people with your product, but we use 5 different categories of value proposition. We use clinical, which is, of course, number 1. We always lead with clinical. If you're going to lead with economic or strategic, and there are a couple of companies that are well known for especially the strategic approach, in other words, work or purchase our equipment and it gives you a strategic advantage, that is a difficult value proposition to sustain. So number 1, clinical. Everybody, including the CFO now, has started to focus a little bit on clinical. Wasn't always the case, but again, because of affordable care, they have to start focusing as well. But if you look at the primary concerns, medical director, clinical, economic, quality, awareness. If you look at the CEO across the board, the CFO, I would probably put, if I could, a small check mark in clinical for them, but definitely economic, strategic. And when we talk about quality and awareness, the concept there is we want to be communicating value propositions that relate to the quality of our company, quality of our product. For instance, we have fewer recalls or no recalls. The awareness is things that you want someone to know about your company, about your product. For instance, while we are a smaller manufacturer of this product here in the U.S., we are the number 1 manufacturer in which gives us a significant amount of resources for product development, for support, for education for you. So again, it's thinking about, as we approach these stakeholders and who we're implementing this model with, who are showing this model, who has the concerns, follow the money is really what it comes down to. So evaluating the stakeholders that you need in your sales process and then making sure that those people are properly engaged. Finally, step 6, the sales process and implementation, implementing the model within your sales force. Easier than it sounds. Again, we've worked with many companies where we've been brought in. I take a look at the models that they're using that weren't adopted. In other words, they were created, a significant amount of time, energy, and money went into developing them, and they're never used. Or I've actually had one particular manager say to me with a specific model, I tried it. CFO asked me a whole bunch of questions I couldn't answer. I got really red in the face, and I never pulled that model out ever again. That's the thing we want to avoid. We don't want that whoever the presenter is, the salesperson, the manager, to feel as though they're dealing with a black box. They can't explain what it is that they're presenting, because then they'll never use it. No salesperson wants to feel as though they don't have the answers. So we talk about the model, the clinical model or economic calculators being part of the overall, I'll call them, suite of collaterals or tools at a salesperson's reach. So things like marketing materials, all the collaterals, messaging, any kind of patient finding programs, COE programs, all of those are in clinical literature especially, all of those are part of the different tool sets that a salesperson has. The economic calculator, the economic sales model should be one of those particular tools. And how do we do that? This is the process. This is how we typically do it. Number 1, you have to ask yourself, do you have, and this is a core primary question. If you can't say yes to this first question, it is going to be incredibly difficult to successfully implement the sales model with your sales force. Do you have a well-defined sales process? By that I mean, and not are you following one of the major sales training programs. There are many out there. Ultimately, that's not what we're talking about. It's, do you have a well-defined sales process so it's understood who are the primary stakeholders that you need to connect with? And oftentimes, I find the sales teams pretty much underestimate the stakeholders that they need to engage. I'd say probably 99% of the time, they're underestimating which stakeholders should be involved in the sales process. So do you have the right stakeholders involved? Are you engaging them at the right time? Do you have the right collateral to engage them in the full process? And then finally, if you can say yes to this, defining where within that sales process you want to leverage the tool, the model. Because if you can't say, this is typically how we approach, let's say, a new account, or this is how we would approach our product launch with our key customers. And step by step, these salespeople approach these institutions as targets. They approach these stakeholders. We know we have to go to VAC and on and on and on, or at least they know to ask those questions and uncover that information and navigate. It will be impossible for them to pinpoint, where do I successfully use the tool? And then they never will, because without an understanding of when and where, they just kind of leave it in their bag and never touch it. The next critical issue, which is also huge, and this is where that manager I mentioned kind of got messed up. What's the skill level of your sales force? And not just the salespeople, the field salespeople, the clinical people, the managers, the VPs. What is their level of hospital business acumen? Because you have to have alignment with the hospital's clinical and business goals. And if you can't understand what those goals are, not just around your product. So a lot of folks, they know they're in the cath lab. They understand the economics around a cath lab, and they're like, oh, we can spin circles around the cath lab manager. But you got to understand more than that. How do you fit in to the bigger perspective of value-based purchasing, of readmission reduction, of cardiovascular in general, especially if it's a COE? So understanding your alignment with that hospital's clinical and business goals, you need to have a certain amount of hospital business acumen. And if they don't, then typically they probably won't use your model. And then finally, again, most importantly, you want the sales force to work collaboratively with the stakeholders versus what we call the dump and run. And the dump and run is basically they give it to the surgeon. They hand the model over and they say, here, you deal with it. If your salesperson can't understand and leverage that model, there is no way that surgeon is going to be able to do anything positive with what you give them. And as I said before, if that model goes unguided into the wrong hands, you're likely to have a negative result simply because people using it don't understand how to use it. So ultimately, these are the key issues that you really want to think about and need to be addressed. So it's a well-defined sales process, figuring out where does that model fit into that sales process, really evaluating the overall sales knowledge or the hospital business acumen knowledge of your sales force, and making sure it is where it needs to be in order to actually accomplish this. And if not, perhaps we need to look at key account managers, field reimbursement people. So there are ways to address it, but you have to really take a look at that first. And then finally, the concept of working collaboratively. There's got to be an approach where we want to develop a relationship with that hospital customer and use that tool not just to communicate information, but to further the development of that relationship. We have a few minutes. What I want to do now is we have a couple of questions that I want to address. So again, while I go through these questions, if you want to take a few minutes, if you have any other questions, type them in, and then I'll address as many as I can. If not, if I can't get to your questions, please feel free, email me directly, mgold, M-G-O-L-D, at tapllc.com, or you can reach out to Jay as well at jay at tapllc.com. And then you can always feel free to call us, 845-596-6508. So the first question, could you more fully explain the OIG issues with building pro forma models for medical devices? Where is the line that we can build a model to without getting in trouble? That's a great question. I get that all the time, usually while we're developing the models, and it is a complicated answer. So let me say that to begin with. That's complicated. There are no clear criteria that the Office of the Inspector General has determined are safe harbors, let's say, or areas where you are most definitely going to get a letter from the OIG. It doesn't work that way. Over 2 decades of experience of doing this, myself and a few other consultants, and again, working with a lot of Fortune 1000 medical device companies and their in-house and outside counsel, what we've come up with is there are a few areas that create problems. Again, using words like profit. You should never use the word profit because Medicare, Medicaid, government dollars, OIG does not want to see hospitals profiting from government and public funds. So we talk about it as reimbursement, net reimbursement. You have to be cautious about the way you select things like DRGs. So if your procedure or product falls within several DRGs, you have to have some basis for determining what is your spread across those DRGs, the weighting. So if you have 100 procedures, how many of them will fall into DRG1, DRG2, DRG3? Because ultimately, if DRG1 is the highest paying and you assign all of your cases in your model to the highest paying DRG, that's a red flag because That's basically overestimating. So it has a lot to do with the way you structure a model to be credible, to reflect the variable nature of your technology and the potential risk, financial risk factors. So those are areas we know you have to be cautious about. And there are many, many more. And, I'm not an attorney, but we can certainly talk about that at a later date. I hope that answered the question. We have another question. What is the average cost of OR time across the country? Another great question. It varies significantly between hospitals. It depends on, and I'll just give you a couple of basic guidelines. It varies based on the region, based on the type of hospital. In other words, is it an academic medical center or is it a community hospital? It depends whether they're billing. Typically, hospitals bill OR time in blocks of 10 or 15 minutes. And then there are levels to the block. So they may have a level 1 through 5, 5 being the most intense, utilizing the most intense level of services, of supplies. So it varies. It can go from a few hundred, could be, let's say, at the lowest level in a community hospital, let's say $20 or $30 for a block of 15 minutes, up to their level 4 or 5, which could be, 100 or 200 for a neurosurgical case if they do that. So there is a study out there, which if the person that asked the question, if you want to email me directly, I will give you a great study that is referenced quite a bit about OR time and saving OR time. Keeping in mind, again, when we talk about saving of OR time, the value proposition doesn't resonate as strongly with hospitals when you say we can save you 15 minutes of OR time, because 15 minutes, while we can say, and maybe it's worth $100, the hospital can't necessarily plug another patient in there for 15 minutes. So again, that's not something that resonates as well with hospitals. We use it a lot, unfortunately, same way we use average length of stay reductions, without truly understanding what's the impact, what's the financial impact and business impact of us using that kind of value proposition with hospitals. So again, if anybody wants a copy of that study, just feel free to email me. Another question, could you give me some more examples, quality and awareness from the value matrix? Oh, absolutely. Awareness really, again, that's the question that where I said there are different things that resonate with different stakeholders. So we had the 5 categories, and the last 2 were quality and awareness. So the concept of quality is you want to talk about the quality of the service you provide. Again, it's very common if somebody's using a distributor sales force that is not a well-structured or well-penetrated sales force. You might have a direct sales force, so you have more feet on the street, which in turn relates back to better quality. You might be in the OR, whereas the distributor can't be. You might provide more education. So that could be a quality issue. Also an awareness issue that probably relates to both. Quality speaks to the quality of your devices, your tools. So I work extensively with European manufacturers, and we find that in surgical tools, some of the German companies, while they might be small in the U.S. and might be a minor player here, the quality of their product and technology is really outstanding, the manufacturing capabilities of some of the companies. And they don't really communicate that enough. While it's very well communicated in Europe where they're significant, it's not well communicated, in the U.S. where they're a minor player. So there are lots of different examples, and even awareness. We worked with a company that spent a significant amount of money on R&D for the products that they're developing, and what that meant, because they partnered with centers of excellence or center of excellences. So ultimately, it meant that those COEs would have a very robust pipeline of new products and technology to continue to set them ahead of their competitors. So again, even R&D spend can be something that is an awareness, and that's even that we would even consider that strategic, because why would you want to partner with my company? Well, again, we can provide a very robust pipeline of technology for you in the future. Another question, for non-cardiac or orthopedic devices, are readmissions still a good variable to include? Are hospital administrators interested in that? Another great question that has popped up again quite a bit. Yes, and there's a reason for that. At this point, a hospital, based on the kind of machine that it is, or the kind of business it is, the business model, it's very difficult for them to reduce readmission in a very focused patient population. I mean, like heart failure patients, sometimes they can and things like that, but ultimately a lot of the work that they do has to be across the board. It has to be very wide, so it does impact a lot of different areas. So they would be open to that. Another question, we have another minute, and I'll try and answer this. In your experience, which type of model have you found more effective, the interactive or live delivery of the data, collection and return with delivery? It really depends on the model, and it depends on the salesperson or the individual that's using it. Both can be done very effectively. Again, it depends on the type of model and what you're trying to sell.